be not that relevant to this present gathering, but still I want to make it a point that we have done our IOP monitoring short-term study at PSR Government Regional Eye Hospital, Kurnool. And this is about IOP monitoring pre-operatively and post-operatively. And our observations are like, inflammation, sorry, I have pointer. Inflammation is a natural response to tissue damage after cataract surgery, and which can be damaging to the ocular environment. And one such thing is steroids can control this, inhibit the production of leukotrienes and prostaglandins, so thus decreasing the inflammation, and it might improve the visual outcomes. But steroids have significant side effects also. One such one is raised intraocular pressure. In our study, our corticosteroid-induced increase in intraocular pressure was seen in most of the patients, and other risk factors for raised IOP are pseudoexfoliation, vitreous or residual cortex in the anterior chamber, and retained viscoelastic materials, and pre-existing glaucomas and advanced yeast diabetes are some of the other causes. The persistent elevation of IOP can lead to optic nerve damage, and here in our study we have done we have seen patients from 15 to 80 years of age group, and all of these patients either underwent uneventful small incision cataract surgery or phaco emulsification. And exclusion criteria was pre-existing glaucomas and previous comorbidities like iridocyclitis and paraoperative complications like PCR or vitreous disturbance, remnant cortex or zonal dehiscence, etc. And patients already on corticosteroid for either systemic or topical use we have excluded, and other connective tissue disorders also we have excluded in the study. And our aim of this study is to evaluate IOP fluctuations following cataract surgery with topical corticosteroids. Here, this is an observational cross-section study where we have selected 200 patients coming to our cataract OPD at Regional Eye Hospital, Kurnool Medical College, and all the patients were recorded, IOP was recorded by non-contact tonometry for better compliance, and compared with the first post-op day, and at the end of first week, and at the end of second week, and at the end of fourth week and sixth week post-operatively. Patients were given topical eye drops in weekly tapering doses with a fixed combination, that is gatifloxacin and dexamethasone sodium phosphate, 0.1% dexamethasone, which is applied at to our patients free at REH. And high-risk patients like patients with diabetes mellitus and other complications, we have included NSAIDs, and patients with dry eyes, we have added lubricants, and these NSAIDs were started at the end of second week post-operate. The following parameters were assessed and significantly and their significance verified by statistical means, and fluctuation IOP from baseline we have taken into consideration, and difference in recorded IOP at different time period we have taken. Age and sex was also considered, and steroid response will be graded according to the rise in IOP from the baseline. That is as done by Armel et al. Here the low fluctuation we call it when the rise in baseline IOP rise in IOP is less than 6 millimeters from the baseline, we call it low fluctuation, and if there is between 6 to 15 millimeters of rise in IOP from baseline, we call it medium fluctuation, and if the fluctuation is more than 15 millimeters, we call it high fluctuation. And the results in our study are, in our study we observed steroid-induced IOP elevation following topical steroids after 4 weeks post-op. The prevalence of steroid responders in our study was 9%, which is really high, as we are doing highest number of cataract surgeries in the world. And mild rise in IOP was seen in about 5.5% of these patients, and moderate rise is seen in 3.5% of the patients. That is 11 patients out of 60 of the patients we have seen, and 7 patients in these 300 patients, 5.5% had a mild rise, and about 3.5% there is a moderate rise, and none of the patients had a severe rise in IOP. The highest mean IOP was noted at the end of 4th week follow-up. That is, the mean IOP was about 23.5, where the baseline IOP was 15.5. The second highest mean was seen at the end of first week. Probably it could be inflammatory reaction. And the males were about 120, 112, and females were 88. And this is the age distribution between 50 and 18. and mean age was about 65.1. And this is the one. The preoperative mean IOP in our series was 15.25. And first post-operative day, there is a dip in the intraocular pressure by 1 millimeter in the mean. And at the end of first week, there is a rise by 5.98 millimeters from the basal mean IOP. And at the end of second week, again it has plateaued back to 0.89 increase. And at the end of fourth week, there is an increase of 8.27 mean IOP from the baseline. And at the end of sixth week, it has come down to again 1.98. That itself shows that, see, in this graph you can see first day there is a dip in the intraocular pressure, but at the end of first week there is a rise in the intraocular pressure, probably because of inflammatory factors also. And then again second week the pressures have come down to near normal, and then but the end of fourth week the pressures have shooted up. And when we have tapered the medications, by sixth week the pressures have come down, but not to the bottom baseline. In our study of 200 patients, they're ranging between 50 and 80 years. We have seen that there is no sex or age-related spike in intraocular pressure. It was evenly distributed among all the groups, and which Kusne et al., who have done about on 3,488 patients, also found the similar results. And there was other study by Han Dong on 222 patients, where he has used becifloxacin with prednisolone acetate compared with becifloxacin with NSAIDs, and there was no for 14 days, and there was no significant difference between the post-operative inflammation. And the study demonstrated that topical steroids are equally efficacious when compared to topical steroids alone, and ophthalmology should consider using two-drug regimen in managing post-operative cataract applications. And the paradigm shift in pharmacotherapy post-uncomplicated cataract surgery has deviated little from the norms as indicated by American Academy of Ophthalmology preferred practice patterns. Based on this current study and others, the authors believe that the pharmacological approach should be tailored to each patient and should not have a similar regimen for every patient, and a standardization of treatment for all patients. Tailoring will increase the compliance, and fewer drugs is always better. But then again, we have to monitor the intraocular pressures before continuing the medication. In our study, 18 subjects, that is about 25, having more than 25% raise in IOP from the baseline, itself speaks the volumes of steroid responders among our post-cataract, uneventful post-cataract surgeries. That's about 9% among study. And 11% has a mild rise, that is up to 6 millimeters increase from the baseline, and 7 subjects, that is about 3.5%, had a moderate rise, that is between 6 to 15 millimeters increase. So I conclude by saying the shortcomings are our sample size is small. 1 minute, ma'am. Sample size is small, and we have not compared between SACS and fake emulsification, and all surgeries were done by either by senior faculty, postgraduates, and trainees also. And so the inflammatory process may be different in different cases, and we have not compared it with other steroid regimens. And a conclusion: the small study highlights the need for IOP evaluation at every post-op follow-up, and need for alternate safe post-operative treatment regimens is the need of the hour. Thank you.
Thank you, sir.